Hello everybody, my name is Thomas Scheine. I'm a sixth-year medical student studying at the Medical University of Lublin in Poland. I'm also an ECG instructor on Lub ECG, and this is my first out of hopefully many movies to come, and I am going to talk about ECG arrhythmias. This is basically what I'm going to talk about today. We'll start with just the basics. Hopefully you've been watching the videos that we have posted before, because I kind of hope you know the basics before you start this one. So if you haven't seen the previous movies, just take a look at them before you look at this. I will start with premature atrial contractions, which is actually the most common arrhythmias. We'll also cover tachycardias, fibrillations, flutter, atrioventricular blocks, and lastly I will talk about bundle branch blocks. Okay, so in the previous movies you were shown these 5 easy steps to analyze ECG strip. And just do yourself a favor and just use these 5 steps every time you are to analyze ECG strip. And hopefully you won't miss anything important. This should cover mostly the basics. So I'll just go through them just to refresh your memory. First of all, we have rate, and when we talk about rate, we talk about the beats per minute, how many beats you have per minute. When we talk about rate and arrhythmias, it's also very important that we know how to analyze the different intervals that we have. We'll talk more about that. Rhythm is the electrical signal originating from the SA node, or is it an ectopic beat? Very important. Axis, hypertrophy, and signs of ischemia, which is also very important. And during this lecture, this is how we're going to solve the ECGs. Talking about the intervals, and this is just something you have to learn by heart, because you really have to know it. Yeah, let's start. The PR interval, which is from the start of the P wave till the start of the Q wave. It's supposed to last from 3 to 5 small squares. If you remember from looking at ECGs, you have 5 small squares in a large square. So you can basically say if the PR interval is more than 1 large square, it's too long. Why is that important? Well, you will have what we call an atrioventricular block. I will talk more about that later. The QRS complex, which is from the start of the Q wave, which is this deflection from the isoelectric line, and to the end of the S, is supposed to be equal to or less than half a large square. And this is also very important. You also have the QT interval. This is a bit more complicated because the QT interval is calculated from the heart rate. So there's no fixed set of numbers that you can use. So we will just skip that for now. We will come back to this in another lecture. Okay, so just to refresh your memory, I have ECG strip here. You can pause the video if you want to solve it, and then we will go through it step by step. Okay, so let's start with the rate. Firstly, we have to figure out if this is a regular or an irregular rhythm. And the way we can find this out fairly quickly is that we count the big squares between the RRs, and you can only take one, because if there's irregularity in the RR complexes, just counting one RR interval will not give you the correct numbers. So we count, start here, 1, 2, 3, 4, 5. and a half. 1, 2, 3, 4, 5 and a half. 1, 2, 3, 4, almost 5 and a half. So we can guess that, we know that this is fairly regular. When we know that a strip is regular, we can count and calculate the rhythm from 1 RR interval, and hopefully you learned that in the previous video. So let's take this RR interval. You can pick wherever you want on the sheet between two R waves. So we have 300, 150, 100, 75 and 60. So more or less 60. That's the rate. Okay, let's look at the intervals. If you remember the PR interval, which is from the start of the P to the start of the Q wave, is this more than one big square? No, it's not. Let's look at the QRS. Let's find a suitable QRS. What about this one? Is this equal to or less than 3 small squares, or half a big block? Yeah, it's nice, it's slim, it's just the way it's supposed to be. Is it a sinus rhythm? Is it a sinus rhythm? How do we figure out if it's a sinus rhythm? We look for P's, P waves, in front of every QRS. Here's a P wave, there is a P wave, there is a P wave, there is a P wave. And sometimes you don't see P waves in all the leads, but as long as you can see P waves in some of the leads, it means that you have a sinus rhythm. And you have a sinus rhythm here, which is good. Next is axis. We use the 2 thumbs up rule, which states if lead 1 is positive, you have a positive QRS. It is. And lead AVF is positive. Yes, you have a positive deflection, not anything negative. You have 2 thumbs up, meaning that you have a normal axis. Very good. Signs of hypertrophy. Well, you have a fairly big R wave in V3 and V4, which might indicate that there is some hypertrophy here. Are we seeing any signs of ischemia? And with signs of ischemia, we're thinking about ST elevation or non-ST elevations. In 1, no. In 2, clearly you have a ST elevation. In 3, yes. You have depression in AVL, another elevation in AVF, and also in the precordial leads V6 and V5. This will, taking the clinical picture into consideration, be typical of an inferior ST elevation myocardial infarction. Did you get it? Perfect. Okay, so let's talk a little about cardiac electrophysiology. What is important to know from this, and hopefully you had it during your physiology classes if you went to medical school. You know that each and every cell in the heart, either they're monocytes or nerve cells, even cells in the vena cava and pulmonary veins, are pacemakers. They can all pacemake if they need to. This means that in any myocyte in the heart, they can start to propagate electrical signal which will propagate through the heart, causing the heart to contract. And if you can see here, monocytes conduct fast. That means the muscles of the heart, muscle cells. The nerve fibers conduct 5 to 8 times faster, meaning that the nerve fibers of the heart is sort of like a highway for the electrical signal. It travels much faster, giving the signal or spreading the signal throughout the heart and propagating their signal to the monocytes, which all cause the heart to contract. But as we know, as I just told you, every cell can start to give off a signal which will cause a contraction, and this will be what we call an ectopic beat. Just to tell you about the golden rule, which makes classifying the arrhythmias very simple, is we divide it first of all into supraventricular and ventricular. Supraventricular basically means that the signal is originating from the atria. The way that you can see this on a ECG, where the signal originates from, is by the QRS complex. If the signal originates from the atria, you will have a QRS complex that is less than 1/2 large square. A QRS complex that is small and slim. And that's what we want to see when we look at QRS complexes. We want them thin. If you have a signal that originates from the ventricle, a ventricular arrhythmia, you will almost always have a QRS complex which is larger than 1/2 large square. Sorry. There is one exception, and that is if the ectopic beat originates close to the bundle of His, meaning that the signal will catch into the bundle branches. You will have a thin QRS complex, but this rarely happens. So as a golden rule, if the signal originates in the atria, you have a small QRS. If it's in the ventricle, you have a big, thick, wide QRS. To demonstrate the golden rule and also talk about the most common arrhythmia, one that you definitely will encounter, we have the premature contractions, either of the atria or the ventricle. These are not connected to any pathology, and it basically means that you have one of the cells in the heart, either in the atria or ventricle, which sends out a signal that depolarizes the heart, starting not from the SA node, but from the point where it originated. And if we just apply the golden rule to these two strips right here, can you guess which one is originating from the atria and which one is from the ventricle? Well, as we talked about, if the ectopic beat is originating from the atria, you will have thin QRS complexes everywhere. If they originate from the ventricle, you will suddenly have a thick one. Same as this one. These are two ectopic beats originating from the ventricle. And here you have an ectopic beat here. This is the ectopic beat. You see you have a regular P, Q, R, and S and T complex here, 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 and then you suddenly have a complex which appears sooner than it's supposed to. This is a premature contraction, and as I said, not connected to any pathology. Let's talk about tachycardia. Still divided into supraventricular and ventricular tachycardias. Tachycardia basically mean that you have a heart rhythm which is more than 100 beats per minute. The supraventricular tachycardia, again applying the golden rule, tells us that we have thin QRS complexes. Okay, how do we know that this is a tachycardia? Well, we count between the RRs. So 300, 150. So about 150 beats per minute. This is a tachycardia. The reason why we know it's supraventricular is because of the width of the QRS complexes. And as you can see, we have P, QRS, P, QRS, T, P, QRS, T. Here it's another example. Here you don't have P's, P waves. Why is this a tachycardia? Well, we can count again. Let's just find suitable RR interval. Take this one, 300, 150. So you have a tachycardia, 150 beats per minute, no P waves. And why were there P waves on the first one and not this one? Well, that all depends on where the signal is originating from. If we go back to the previous, we can say that the P wave, the signal, is originating from somewhere close to the SA node. Just think how the signal travels towards an electrode. In the other one, we can most definitely say that the signal is somewhere closer to the AV node because we don't have P waves. So we're not able to read any activity in the atria. Okay, ventricular tachycardia. Again, applying the golden rule, as we see on this QRS complexes, they are large, larger than 1/2 large square, larger. And you might think, okay, why is this not a ventricular fibrillation? Well, firstly, we haven't talked about fibrillations yet. We will come to that in the next slide. But as you can see, they are very regular. They are monotonously regular, and that's the hallmark of ventricular tachycardia. By the way, this is life-threatening arrhythmia, and you would need to defibrillate these patients. Here again, you have a sort of ventricular tachycardia, and you see they are very regular, and you see the heart rate is about 150 beats per minute. Okay, so what about this one? As we can see, applying the golden rule for the QRS complexes, or if we can even call these QRS complexes, the complexes are wide. They are wide, so we know that the signal is originating somewhere in the ventricle. And why is this not a ventricular tachycardia? Well, it's highly irregular. As you can see, this doesn't look at all like the previous pictures. They are not regular. This is total chaos, and total chaos is the hallmark of fibrillations. And basically, fibrillations mean that you have multiple foci in the heart which sends out signals which depolarize and repolarize without any control. This is total chaos of the heart, and that's a fibrillation in comparison to a tachycardia, which is regular. There's no chaos. There's still just one foci that sends out a signal that propagates through the heart. This is also a life-threatening condition which will need defibrillation. When it comes to atrial fibrillations, which is much more regular, in fact it's very, very common. You still have this chaos, but it's in the atrium. And as you know, the atria and the ventricle, they're separated, and the only way from the atria to the ventricles is via the AV node. And the genius thing about the AV node is that it can selectively choose which signal they want to propagate through the ventricle, meaning that even though you have chaos in the atria, you can still have a much more order in the ventricle. It is the hallmark of atrial fibrillation is its irregularity between their QRS complexes. You have no visible P waves. Even though you think you might see P waves, they're not P waves. They are chaotic waves that we call F waves, or fibrillation waves. Okay, so you see a normal ECG on the top here, and then you see atrial fibrillation here. You might think that you are, what about these waves? Aren't they P waves? No, they're not. This is chaos. And you're lucky if you get an ECG strip like that, because you can even get a flat isoelectric line. It doesn't have to look like this. And the way that you can be sure that this is atrial fibrillation is the irregularities between the RR intervals. As you can see, there is total chaos between them. This is highly irregular. And this irregularity and the absence of P waves in front of the QRS complexes is the hallmark of atrial fibrillations. Here is one more, and here you can see there's not that much chaos on the isoelectric line. As you can see, it's fairly flat, but there are no distinguishable P waves, and you see that it's highly irregular intervals between the R's. This is atrial fibrillation. You have the same here, a little more chaotic, but still the irregularities is what gives it away. And as you can see, the QRS complexes are small. They're not wide at all, meaning that the arrhythmic foci is in the atrium. Then you have flutter. Flutter is basically a form of extreme tachycardia. It can either be atrial or ventricular, but these are still just a form of tachycardia. You will often see that flutter changes. They switch from tachycardia to flutter to fibrillations to flutter to fibrillations. The characteristic of atrial flutter is the sawtooth appearance. If you can see this, if you were to remove the QRS complexes, this would look like saw teeth, and is highly characteristic. So basically, you just have to think, if you have ventricular, or if you have a tachycardia which is very fast, over 160, always just think that this might be flutter. But look for the characteristic sawtooth appearance. Then we go to the atrioventricular blocks. And a block basically means that you have a miscommunication between the atria and the ventricle. This is a conduction malfunction. And you can divide this into 3 different degrees. You have the first degree AV block, which means that all P waves are conducted. Please remember, first degree, all P waves are conducted. The only thing, and this is why it's important to follow the 5 steps that we have taught you, is that you have a prolonged PR interval, more than 1 large square. As you can see, the PR interval is too long, meaning that the signal from the SA node takes too much time getting into the ventricle. It means you have a first degree AV block. All P waves are conducted. Still, after every P wave, you find a QRS complex, as you can see. Not so on the second degree AV block, where only some of the P waves are conducted into the ventricle. Only some. And just to make it much easier for you, we have of course divided the second degree blocks into two types. We have Mobitz type 1 and Mobitz type 2. So let's talk about Mobitz type 1 first. This is what's called the Wenckebach Mobitz. Why it's called the Wenckebach, I do not know. It basically means that you have a prolongation of the PR intervals in every heartbeat, but not all P waves are conducted. So let's see, we have the first interval here, PR. We have the second, and as you can see, the PR interval is prolonging, it's longer. The third, we have a very long prolongation. And on the fourth, it's not able to conduct into the ventricle. So you have 3 P waves followed by QRS complexes with a prolongation of the PR interval in every beat until it cannot longer send the signal into the ventricle. And just to make it a little easier, I put in a picture of Dr. Wenckebach himself, and as you can see, in Mobitz type 1, you will have room for one picture of Dr. Wenckebach before the P waves are no longer conducted into the QRS, into the ventricles. So in Mobitz type 1, you can fit one picture in the last QRS, in the last PR interval. Mobitz type 2, the same. You have only some of the P waves that are conducted into the ventricle, giving rise to a QRS. As you can see, you have PR interval, then you have a P wave which is not conducted. P wave, QRS, P wave, QRS, P wave, not conducted. And do you think you could fit a picture of Dr. Wenckebach in here? No chance, no chance. It's just not big enough. This is type 2. You would never fit it. So which one is this? P, Q, R, S, T. P, Q, R, S, T. P, Q, R, S, T, and then nothing. And you can even fit a picture of Dr. Wenckebach. So this would then be type 1, because you can only fit one picture. Get it? Very good. Third degree AV block, no P waves are conducted into the ventricles. Not a single one is conducted. As you can see, you have a P wave, yes, and you have a QRS and a T. Suddenly you have a P wave occurring in the middle of, where you really wouldn't expect it to be. And then you have a P wave showing up here, and a P wave showing up here, and a P wave showing up here, and so on. Meaning that there is no connection between the atria and the ventricle. Nothing. They work totally independent from each other. It means the atria is living its life and the ventricle is going on living his life. Same here. P, P, QRS, P, P. So the P waves are regular. The QRS complexes are regular, only they are independent of each other. So, to sum it up, first degree AV block, all P waves are conducted, but you have a prolonged PR interval. Second degree, some. Third degree, none. Then we're approaching the end of this lecture. I will just say a few words about the bundle branch block. It's not the easiest word to say. The bundle branches are these nerve fibers here. These are the bundle branches, and their job is to conduct the signal and distribute it evenly around the heart, giving rise to a normal beat. When you have a blockage of a bundle branch, it means that the signal will propagate through the ventricle at a much slower rate. And also, if you have this is clearly a ventricular arrhythmia, so we should be able to look into our crystal ball and think, how big should the QRS complexes be? Well, they should be bigger. They should. Not always, but they should. And the reason for this is that the block is could be a complete, or yeah, they should. Right bundle branch block and left bundle branch block. You have actually several diagnostic criteria for this. We will just focus on one. So unless we're going to be cardiologists, we basically have to keep it simple so that we can send these guys that we think have a bundle branch block to a cardiologist, or treat them for one of the things that a bundle branch block might mean. We will talk more about that in another lecture. But basically, as you know with the precordial leads, V1 and V2 looks at the right side of the heart. And if you have what we call a biphasic QRS in leads V1 and or V2, which is like this, looks like bunny ears, or McDonald's, or it's an M. If you have this M in V1 or V2, then this might be a bundle branch block. So let's see. If we look at the QRSs, they are not that big. The QRSs are big here. And we're supposed to look in V1 and V2, and we see these characteristic M's, these bunny ears, which indicates that this might be a bundle branch block. Left bundle branch block, we know that V5 and V6 of the precordial leads look at the left side of the heart. So if you have these biphasic QRSs, bunny ears, M's, whatever you want to call them, in lead V5 and or V6, it's indicative of left bundle branch block, as we can see here. And here we clearly see that the QRS complexes are fairly wide, so there's no doubt that this is a ventricular arrhythmia. I hope you understand that this looks like an M, even though it didn't look as characteristic as they did on my previous example, but hopefully you get the picture. And that's all I wanted to say. It's the first of my movies here on YouTube. If you have any comments, please comment under, and hopefully I will make a new movie soon. Thank you very much.